Hello viewers, today I am going to demonstrate a modified Widman flap surgery to you. But before we see the surgery, let us discuss one important question. How do you decide the design of a flap? Now there are various factors which determine the design of a flap. Most important of these factors are the thickness of the gingiva, then we have the contour of the gingival margins, then we have width of attached gingiva, then we have recession, because we don't want to do a surgery which will increase the recession in that area. Then we have the aesthetic zone. The maxillary and the mandibular anterior areas, they are of prime aesthetic concern. So considering all these factors, we design the flap. And now let us see how a modified Widman flap surgery is done. So we have a patient here with chronic generalized periodontitis. You can see the moderate to deep pockets. The pockets are deep, especially in maxillary posterior area. And first of all, we isolate the area with the help of gauze. Here you can see the isolated area. Now we irrigate the area with antimicrobial solution. We are using povidone iodine in this case. And then we start with the internal bevel incision. Now in case of modified Widman flap, we have three incisions. First incision is called as the internal bevel incision. The second incision is called as the circular incision. And the third incision is called as the horizontal incision. So the first incision or the internal bevel incision is given 0.5 to 2 millimeter away from the gingival margins. You can increase or decrease the thickness of the incision according to the thickness of the gingiva in that area. You can see that I have given the internal bevel incision and I am increasing and decreasing the thickness of the incision according to the thickness of the gingiva. You can see that in canine area I have tried to reduce the thickness of the incision. And this is how we complete the incision, the first incision. You can see the incision line clearly now. And then we go on to the palatal side and we start the first incision, the internal bevel incision. In the same way as we put it on the buccal side, we put this incision on the palatal side. It is a bit difficult on the palatal side to put this incision, so you can use a contra angle BP handle so that you can easily place the incision. So this is how we complete the incision on the palatal side. Then we reflect the flap. Now you can see that I am reflecting the flap. So you can see that using the periosteal elevator, I have tried to first elevate the interdental papilla and then I'll try to reflect the flap on the buccal aspect of the teeth. So first of all, you have to release the interdental papilla. Then I'm trying to release the buccal flap. Here you can see that I have elevated the flap. There should be approximately 0.5 to 2 millimeter of bone exposure, because our main motto during this surgical procedure is to expose the bone defects. So only the marginal bone is exposed. Overexposure is not going to help in any way. In the same way, we go on to the palatal aspect and we elevate the interdental papilla first, and then we elevate the palatal aspect of the flap. Here you can see that the palatal flap is being reflected. I've tried to be a little conservative on the palatal side because our main motto is just to access the bone defects. Now this is the second incision, the sulcular incision. You have to put the BP blade into the sulcus and then you have to go till it feels the resistance from the bone. Now the third incision, or the horizontal incision, you can use an Orban knife for that, or otherwise you can use a simple curette and then you can pull the wedge of the tissue out of the flap. You can see that the wedge of the tissue is coming out. This is the tissue which contains the pocket lining. Now you can see that the same sulcular incision is being placed on the palatal side. And then with the help of curettes, you pull the wedge of the tissue out from its place. The curettage of this area on both on the palatal and the buccal aspect has to be done thoroughly, so that there is no granulation tissue or any infected tissue remaining after the surgery is over. You can see that the flap has been reflected, and we see for any granulation tissue or infected tissue, remnants of that or any tissue tags, we identify and then we remove them with the help of curettes. As we have a complete access to the root surfaces now, so we can do root planing along with this procedure. So this is how we remove the granulation tissue and the tissue tags. Then we start with the scaling of the root surfaces. As you can see that all the root surfaces are visible clearly now. So we do the scaling both on the palatal and on the buccal aspect to remove all the deposits on the root surface, including the calculus, and you can see that scaling has been done. Now after this procedure is over, you have to inspect the flap. You can see that after we have seen that everything is neat and clean, there should be no bleeding from the area and it should be neat and clean. As you can see that there is very minor bleeding which is required in this area, and then the flap is being inspected. You can see the clear area. All the root surfaces are inspected for any deposits, and then at last we go ahead with the suturing procedure. I am putting a modified continuous sling suture here. And this is after suturing. You can see nicely placed sutures. The interdental papilla, they are well approximated. This is on the palatal aspect, so you can see that there is no bleeding at all and the teeth surfaces are clean. This is 1 week post-operative. Thank you for watching, and you can see more periodontal and implant surgery videos at periobasics.com.